Good afternoon. I'm Daniel Benjamin. I'm the director of the Dickey Center, and I am delighted to welcome you to today's lecture by Dr. Eric Goosby entitled What AIDS Has Taught Us, Lessons from the Global Fight Against HIV and the New Global Health Agenda. Eric Goosby, or as we should probably call him in the best Teutonic fashion, Ambassador Dr. Professor Director Eric Goosby, is one of the heroes of public health today. He's best known for the 5 years he spent at the State Department from 2009 until just a year ago, during which time he served as the Ambassador at Large and U.S. Global AIDS Coordinator, where he led all U.S. government and international programs dealing with AIDS. In his capacity, Eric Goosby was the U.S.'s senior global health diplomat, and he advanced the nation's mission to improve and save lives and foster global sustainability. Most notably, he oversaw PEPFAR, the President's Emergency Plan for AIDS Relief, the largest public health endeavor in history, with over $45 billion invested in 10 years. Under his tenure, the program expanded treatment to 6.7 million people, more than a fourfold increase since the beginning of the Obama administration, and it cared for more than 5 million orphans and vulnerable children, strengthened combination prevention approaches to include prevention of mother-to-child transmission, male circumcision, and widely expanded counseling and testing services in the most heavily affected countries in the world. This was not Dr. Goosby's first foray into government, I should add. Indeed, in the area of public health, he has been what Teddy Roosevelt would call the man in the arena. He had previously been director of the National AIDS Policy at the White House under President Clinton and director of the Ryan White CARE Act at the U.S. Department of Health and Human Services. He has had decades of experience with HIV/AIDS, ranging from the early years, treating patients at San Francisco General Hospital when AIDS first emerged, to his service in government. Between his tours in Washington, Ambassador Goosby served as the founding CEO and chief medical officer of Pangea Global AIDS Foundation from 2001 to June 2009. And during this period, he also had a faculty appointment at the University of California at San Francisco as professor of medicine. During this period, he played a key role in the development and implementation of HIV/AIDS national treatment scale-up plans in many resource-poor countries, including South Africa, Rwanda, Uganda, Tanzania, Cote d'Ivoire, China, and the Ukraine. Since leaving the government last year, Dr. Goosby has returned to his alma mater, UCSF, where he taught for many years. He is professor of medicine in the Global Health Sciences program, and in addition to seeing patients and teaching students at the university, he is establishing a Center for Implementation Science in Global Health. I think that perhaps one of the distinctions he has that probably gets the least attention, but probably is most relevant for our talk today, is that in December 2012, Secretary of State Clinton asked Ambassador Goosby to serve as the founding director of the Office of Global Health Diplomacy at the Department of State, in addition to his duties as Global AIDS Coordinator. And that office guides diplomatic efforts to advance the U.S. global health agenda and to improve and save lives and foster sustainability in partner countries. I think that gives us a sense of where we as a nation are going, where the Western community is going in terms of its engagement in global public health, and I very much look forward to hearing more from Dr. Goosby today. I hope you'll join me in welcoming him here to Dartmouth.
Well, thanks, Dan, for the really kind introduction. I appreciate it. It's really an honor to spend the day with you today. You guys have got me here and kept me busy from the morning on in very interesting conversations with many of your colleagues throughout the institution. Dartmouth has a wonderful history of liberal education. And I think that the Dickey Center for International Understanding is a wonderful reflection of that long-term commitment to better present the complexities of international relationships so individuals who are not maybe in that dialogue understand the importance of that dialogue. And I think this is a wonderful opportunity to be part of that. I'm going to, we can, with the size of the audience, feel free to interrupt me and stop, clarify, or add your own thoughts to it. I'm going to zip through some of the salient features of PEPFAR and then kind of talk about, in light of that, what does the global health topography look like, what the discussion has presented in the UN General Assembly, the incorporation of the MDGs and the post-2015 discussion around what do we do after the 2015 deadline, and the opportunities that are out there that it's clear Dartmouth is positioning itself to play a leadership role in. So as Dan said, PEPFAR is a remarkable program. It was a real honor to be able to lead that program for the last 4 or 5 years. It began at a time when there were fewer than 50,000 people on antiretroviral therapy in sub-Saharan Africa. Out of the 34 million people that are on the planet and HIV positive, 27 million of them resided in sub-Saharan Africa during that period. About the same number have died from HIV since the 1981 kind of when it emerged. In 2003, PEPFAR was passed, and it was an attempt to respond to the overwhelming morbidity and mortality that was present in really about 22 countries globally. Most of those countries were in sub-Saharan Africa. The life expectancy decline of over 20 years was evident in many of the southern countries in Africa. The healthcare delivery system was saturated. HIV has the peculiar feature of deteriorating immune function to the point where susceptibility to opportunistic infections dominate, and in settings where there are hospitals and medical systems that can absorb, that is where individuals end up. And in the United States and Europe, we saw the same phenomena. Even though our seroprevalence was 0.6, nationally, we had our medical institutions in inner cities that were predominantly looking at indigent AIDS care patients were 70% and 80% full with AIDS-related diagnoses. That was in the early 80s. These hospitals in sub-Saharan Africa had 3-4 people in each bed, people on the floor, people in the hallways, because they had nowhere else to go. The loss of working age population hit the economies hard, and it was the economic threat matched with the instability that occurs in families, in societies, and in countries where the seroprevalence was 17 to 30% in those countries. It was that reason that people started to look at the security elements in this that Ambassador Holbrooke made famous in a presentation to the UN General Assembly in about 2000, that was. So, PEPFAR, Dan went through the numbers. Out of the 10 million people in sub-Saharan Africa on antiretroviral therapy now, 6.7 million are from PEPFAR-related programming. More than 1 million babies from prevention of mother-to-child transmission. Really almost a year ago now, we reached the 1 million baby mark for having prevented that child from becoming HIV positive. We began and moved to scale male circumcision, which drops the chance for that man to be infected with an exposure by 64%. Also protects the women that he has relations with later by actually showing a drop in the seroprevalence of partners of men who've been circumcised. That's now been confirmed. We have, of the 17 million people that received non-antiretroviral care under PEPFAR, there were 5.4 million orphans and vulnerable children who'd been orphaned by HIV, parents died, family unwilling to care for them, or they had died also. It's the largest orphan program in the world. It is larger than the Catholic Church by quite a bit, and takes care of children from birth until they're 18 years old for food, clothing, housing, education, and job training. We also use the children as they turned 17, 18 years old as peer educators. We're able to funnel them into some paying jobs. And with private-public partnerships with mostly multinational corporations, we're able to target them for specific entry-level job training in most of the countries that we worked. I think that in order to reach the HIV-positive pregnant woman, we had to do 57 million people tested. It was part of the effort globally, but most of those in sub-Saharan Africa, to identify 780,000 HIV-positive pregnant women in 2013, which is the last available data. That prevented about 230,000 babies from being born. The total number of pediatric AIDS cases is now 490,000 globally in the whole world. Comes from 16 sub-Saharan African countries mostly, about 89% of it. And we have been able to drop that down to about 130,000 now. Over the next year, I think we will get it down to below 50,000 born, and those will be people that, women that did not enter prenatal care at all and were not tested. So, breathtaking data. This is just to show you the life expectancy drop that occurred at the end of the 90s, late 90s, early 2000s. In every one of the countries listed, you see a precipitous drop in life expectancy, halving a third to half in many cases. PEPFAR and also the Global Fund, which started in 2002, Global Fund took longer to get program on ground, but they've achieved that and moved numbers as well. So it's a combination of PEPFAR and the Global Fund. But those numbers have been turned around and are approaching their pre-epidemic numbers. But what is remarkable about it is the stabilization of the economies that occurred relatively quickly with the availability of effective treatment. Just to give you a visual of the burden of the infection, the green is sub-Saharan Africa. We're the blue line on the top, the perimeter line in North America. You can see Eastern Europe and Central Asia staying pretty stable in terms of not diminishing in its numbers. But everywhere else you see a drop in the number. But you do see the extraordinary predominance in Africa. The progress is not equal in each country. Each country, actually each province within each country or each state is a different engagement, a specific engagement that requires a mapping of where people are. Trying to understand where the new infections are is a tool that we heavily utilized over the last 5 years, looked at incidents, and we're able to understand where, not just who, but both who and where the new seroconversions or new HIV-positive people were occurring. Uganda and Angola are the two outliers over the last 5 years that did not drop the number of new infections. They actually increased a little bit, not above their 2003, 2005 levels, but trickling back up with new seroconversions, mostly because of a lack of combining the prevention interventions appropriately where the new seroconversions were occurring. So a mismatch of the intervention with the population. Ugandan leadership, both U.S. and Ugandan, also felt that the preference for low impact prevention interventions dominated there and became a political fight. So we were unable to move them to condom distribution to high-risk populations, to testing of high-risk populations. They did not put any money into treatment, which, as I'm sure most know in the room, treatment is our most effective prevention intervention, dropping the ability to infect another. If you go on antiretroviral therapy and your viral load goes to undetectable, you drop your ability to infect a partner in an unprotected sexual encounter by 97%. It's better than a vaccine, and the testing and subsequent studies that have come out have confirmed over and over again this phenomena. If you approach 60 to 70% of the population who is in need of antiretrovirals and put them on antiretrovirals, you see a flattening and then a negative number of new infections. So it shifts the curve from going up to flat and then to negative. People who, in the blue countries here, we had on average a 47% drop in incidence in this 3-year period. That's continued this last year as well. That is the first time the incidence dropped in the epidemic, except in isolated sites in the history of the epidemic since 1981. So this is a turning point that is profound and unprecedented and has persisted. And I attribute it to the concentration of high-impact prevention interventions, the most significant of which is the treatment, but male circumcision, PMTCT, the prevention of mother-to-child transmission, targeted condom distribution, counseling and testing in those populations that reflect the highest incidence are the key kind of recipe to flattening and dropping your incidence. Just so we don't forget, the key populations vary by location. The green are men who have sex with men. The beige in North America there is African American women. The blue, pale blue, is injection drug users. The black dots are prison populations. But you can see that it is variable throughout, but that there are recurring themes and the same populations continue to dominate in number of new infections. These are just examples of looking at incidence curves and deaths. Malawi giving you an estimate of new infections and AIDS deaths in 90 to 2013. The alignment of a drop in new infections, a drop in incidence, with a drop in deaths shows that your combination of prevention interventions is occurring kind of at the right rollout. Your movement to scale is accommodating and blunting the ability for the virus to get into the population and root. Mozambique did not have that alignment. Delayed scale-up of combination prevention is what you saw in the programs. Cameroon and Nigeria are also examples of this. Delayed scale-up of combination prevention, delayed scale-up of combination prevention in Nigeria matched with poor coverage. They had whole swaths of the country that were unresponded to. Kenya and Uganda, again showing new infection drop with moderate scale-up of combination prevention on the part of the Kenyan government, later corrected, but took a political fight to do that. And then the earlier response with stalled scale-up of combination prevention in Uganda that we talked about earlier. It is the another reason that a diplomatic dialogue is needed. All of those decisions for moving rapidly with a scale-up or not came from the highest level in government, usually the president. Minister of Health was often the weakest cabinet member and unable to argue against a strong personality in the president's position, and it required a convergence of our the United States diplomatic kind of levers, as well as the science. But the science didn't win. It required a steady dialogue to get the final movement. PEPFAR in the future is looking at continuing basically the same formula. It has been very effective. The areas that are going to be tweaked are moving our colleagues in country instead of PEPFAR and academic medical centers, mostly in North America, doing the impact evaluations. PEPFAR is now in a concerted transfer of capability to ministries of health, so they develop, learn, and incorporate the tools of impact evaluation into their budget preparation and strategic planning. This will give them feedback in real time to change the priorities as the needs of the population who use and depend on these services change, to continue to be relevant and responsive. It also empowers our colleagues in the ministry to see that they have the ability to change trajectories and broaden, increase, concentrate the impact of prevention interventions, and putting that expectation on ministries as opposed to having it go thousands of miles away to be analyzed, and it virtually would never get back to the planning process in country to inform it. So those feedback loops will now start to show themselves, and better management will come out of it. It leads to a sustainable program, more sustainable, and strengthens the partnership that will continue for many years in the donor resource need, because that's not going to quickly come back, and allows the countries in a much more specific way to be accountable for their own monitoring and evaluation. So, applying proven systems and practices, rigorous evaluation methodologies, nurturing or creating new partnerships, especially with academia and the private sector within these countries, is what I believe we need to now turn to do. Civil society and governments do not use the resources that are around them to think in their planning or implementation processes in country, and as a result are less responsive to the changing needs of the population that depend on the services, but also have, I guess, atrophied a lot of the feeling of being responsible for the outcomes. And that disconnect has, I think, slowed down their Ministry of Health's ability to manage, oversee, monitor, and evaluate these programs in the way that they need to. That capacity expanding challenge is the challenge in front of us. If we are going to move to a planet that has a basement of essential health services for those with the highest burden of disease, and all these countries are those countries, they need this. And I feel we will not be successful if we continue to expect a parallel system of care to come in from outside, parachuted in, to create an instant capability that delivers excellent care, but it's excellent care that stays for 3 to 5 years and then moves on. Once it moves, the capability goes completely away. So having seen that over and over again, I think it's time that we start to look at a more sustainable model. We have known what works, but we're not delivering it. It's certainly true for HIV, but it's really true for any disease you can name out there. All the infectious diseases, TB is another big problem that we have known about for 5,000 years. We've seen TB infect human beings. We've had, since the 40s, effective drugs. Since the 50s, very effective drugs. And late 70s with rifampins coming in. But have been unable to put those resources in front of the people who carry the disease long enough, a 6 months treatment course, to get a cure, not just to maintain them, but to cure them. And it's those types of tragic disconnects that I think we need as a global public health community to start to call for what it is and look at strategies that can run parallel to the parachute-in parallel system approach that on day one starts to capacity expand those delivery systems and those managing them to take care of their own in an excellent fashion, and pull our role to be one of mentoring, technical assistance, perhaps centers of excellence, a referral site for more complicated, difficult patients. It's not that there won't still be a critical role for multinational NGOs to play, that's for sure. It's just changing the what we do, even though we are still engaged. Discrepant results around the globe are unacceptable. TB cases in 2013, the 9 million incident cases that occurred last year for TB is the 1.5 million deaths. It makes it the second killer on the planet. And I think the emergence of multi-drug and XDR TB making it the aerosolized organism that can spread by aerosolized spread, but it can kill you. You can get it in a line, being in a line in an airport or in a store. And we have had the tools to treat this effectively really since the 60s, well delineated, well studied, evidence in place. But we have, in very few places, actually put it in place. The burden of disease for TB remains. And again, we know how to diagnose it, we know how to prevent it, and we know how to cure it, but we still can't get our systems to orchestrate that medical delivery system to get in front of the people with the disease. You name the disease. Maternal and child health diseases are the same. Our African countries have rates that have been dropping since the 1990s, but they are still unacceptable. A woman in Africa pregnant has a 20 times greater chance of dying in childbirth than a woman in North America. Knowing the tools that will prevent that death, knowing how to put them in place, and have examples and studies that have shown the synergy between these types of interventions, but we have failed to do it over and over and over again. We are complacent with a slow, kind of glacial response to the progress that we see in our kind of development interventions. There's no urgency to doing it better. We are okay with just enough, good enough. And I think that we have to aggressively acknowledge that we go slow, and we need to change how rapidly we are able to put the capability on the ground and transfer the knowledge to run it themselves to our colleagues in country. Non-communicable diseases are the same. The childhood diarrheal diseases, hypertension, diabetes, coronary artery disease, the lack of cervical cancer breast screening for early disease, which is curable. In PEPFAR, we took both cervical cancer and breast screening, put it on top of PEPFAR platforms in Zambia, in Tanzania, and in 2 provinces in South Africa, and have been humbled by how easily the disease can be identified and treated before it causes any real symptoms. It's not just about the money. There's a lot of money on the table. PEPFAR got a lot better at using the money it had. We had an 11% cut over the last 5 years in PEPFAR, not including cost of living cut. That would add, if you added that, it would be more. But just with the 11% cut, we were able still to expand our services in every category by 3 to 5 times what it was in 2009. And that was from doing common sense adjustments, collapsing procurement distribution systems. Instead of having 100 clinics with 100 different procurement distribution systems, we have 100 clinics with one procurement distribution system, one management system that ran that. Same for management of clinics. Instead of 100 medical directors, we have one medical director for 20 clinics. An efficiency of scale. With drugs, we went to generic. In 2009, it was about 57% was brand, and we eliminated that. The only brand drugs that we purchased in PEPFAR were for pediatric second and third line cases. So kids who'd failed the first line, we would get them brand drugs for the second. And there are a few that were going into third line. Years of effort have not seen the development of enough sustainable programs that have the lasting impact. We do studies and document in the evaluation that this is a better way to do it. We save more lives, we do it cheaper, and we do not then in our development dialogue in the next iteration make sure that those high impact interventions are the ones that move forward and are funded. We still let the low impact interventions come in for a variety of reasons and persist. The most central of which is individuals who have learned a skill set not wanting to change it, not wanting to lose their job or transform themselves into a different job. And it's the protection of that payroll worry that has dominated. We are clearly in a constant state of emergency. Program failures, we see repeated startup attempts instead of moving to kind of a more mature form of disease response. An example of that is our immunization efforts. We see UNICEF year after year deploy a immunization strategy by taking people from who are not part of the medical delivery system, parachuting them in and having expanding concentric waves of immunization. It's effective, it works, but UNICEF does it every year in the same country, year after year after year. And there is no attempt to transfer those skills to the Ministry of Health to allow them to start in the subsequent year to use their own clinics and hospitals, school system to deliver those immunization campaigns. I think that the system responds better when there is an emergency in some ways, but in others it doesn't. We're not learning from our failures or our successes. Programs come and go, they finish, they go away. The evaluation or discussion of lessons learned from what that particular program did in that particular set of clinics and hospitals is lost. And another program comes in and repeats, a half of the same approaches that were less than optimal or flatly did not work. The kind of psychic dynamic with the donor and the grantee, the country, the Ministry of Health, is not of equal power. So the ministry often does not feel that they can push back in the dialogue saying that we want this and we don't want that. They feel the money will walk out the door with that kind of a dialogue, and it often does. So they don't engage. We need to not view this as an acceptable way to work in partnership or with colleagues. We need to change the way we think about health system delivery to create locally owned and sustainable solutions. And I've created a stool that is to represent the health delivery system, the effective, successful delivery of health care to a specific population. That the construction of that stool, the definition of what the standard of care is informed by the science, but it's also informed by the history in that country and the acceptable standard that the professions in that country have accepted as theirs. But it can also be supported, and rarely is, by other institutions within the society that often do not have a relationship to the Ministry of Health. and we need to acknowledge those relationships and make those linkages with them. Academia, the private sector, the health diplomacy and advocacy, the national and local governments, the Ministry of Health, but it's not always the Ministry of Health. It's the process that plans and implements that we're really talking about, and then civil society as the kind of reflection and means through which those who use the services can talk to the planning and implementing decision makers. Those pillars of support need to be together and linked to create a stronger Ministry of Health. I think to create that integrated health system, each one of these stool legs needs to be identified and explicitly linked to the ministry to support them as they move through their planning and implementing challenges. In the United States and Europe, we often have relationships with academic medical centers and departments of health. The AIDS epidemic was an example in the early 80s of those partnerships emerging really all over the United States. The Ebola outbreak with the Center for Disease Control playing a central role, and state departments of health playing a central role, are taken for granted in many of the developed settings. In these countries, again, with the heaviest burden of disease, these relationships are not present, and we need to actively work to develop them. It's a balance of power among the government, the private sector, academia, and local and community civil society. The private sector often has true expertise in country available for procurement distribution systems as well as mid-level management. Companies understand the importance of mid-level managers, know how to assess a system for its management strengths and weaknesses. And we have, in many instances with multinational corporate interests, taken this company that has already invested in the country by being there and with its employees and caring for their health and the health of their families, has already made a huge commitment to long systems that they have nurtured. It's also the norm that multinational company medical delivery systems respond to anybody who comes in the door. They don't just say employees and family. And those that are doing that are prime for taking the next step into working with the government around these management issues. We're looking at field acceleration, resource alignment, and changing science and ultimately changing practice. The field acceleration, accelerating implementation, reduce the time from engagement to the corrective outcome impact that we're trying to seek and obtain. Look for local expertise to support, nurture, and reflect the accuracy, integrity of that system. Evidence-based metrics, having that become the norm for the ministry is already well along in the HIV/TB arena in most of sub-Saharan Africa, but in other disease processes is not. And I think that evidence-based orientation needs to be something that we support. And then taking that longer trajectory commitment to move and stay with that ministry in the dialogue with the planning and implementation process over years to continue to support them in doing that in an acceptable way that gets the outcomes that they're after. Understanding what the investment from donor and from their own money is buying in way of outcome to have what impact is basically what it gets down to. So the decision makers can understand that when they put money into this activity, they should see this drop in incidence. And we have gotten enough water under the bridge to be able to give them a guide to the different combinations of prevention interventions that result in what type of impact on the slope and the drop of incidence in the country. It's that kind of specificity and metrics that ministries of health need to take care of these diseases, and it is what we are not communicating to them. Resource alignment is critical. There is enough money to do a whole lot more. It may not be enough to do everything, but it is enough to do a whole lot more than we're doing now. And we think that the rigor that needs to go into understanding what the donor dollar is doing and how it is additive with the other donor dollar, and most importantly, how it's additive with the country's investment in the effort is the key kind of recipe to make this go a lot farther. I am confident that if we look at what we're spending on, we can do it better for less money and save more lives. That same type of alignment with industry and their skill sets in procurement and in mid-level management is critical. Changing the science and the practice, replicability, knowledge transfer, systems-based practice, and the leadership ecosystem, talking about the relationships with the ministry, with those kind of resources within the country, and having individuals outside of the country available when resources are not present in country to do it. Donors don't fund those relationships now. We will fund somebody coming from North America, thousands of miles away, to deliver a mentoring or kind of consultation like a consultant, but donor money is not used for kind of in-country supports, and I think that's has been a tragic oversight. When you do engage this local ecosystem and invigorate it, you see a pride and a accountability that was not achievable when you had people reporting back to Geneva and Washington about the outcomes and impacts that their investment brought. Evidence-based acceleration, we did this in PEPFAR. We had a 73% reduction in the cost of antiretroviral therapy. It was $1,400 per person per year in 2009. And when I stepped out of the door, it was $335. It was all the things we talked about, getting smarter about procurement distribution, not having distribution occur by air freight, just by ground, moving from brand to generic formulations for drugs, having the ability to take what I would say the local technical assistance mentoring to look at systems of care, the analysis of data that had been analyzed and aggregated, had been rather aggregated but never analyzed, years of aggregating data. They'd send it to PEPFAR, to Global Fund, but never sit down and look at what it means for their programs, and never reflect that back into their planning process or budget development. We were able to do this with common sense type of interventions. This isn't rocket science. Rwanda is an example of a country that took divergent funding lines from donors, Global Fund, PEPFAR in particular, other bilateral programs, but not many, and matched it with their money, put their money into it. They are almost all donor money driven, but this is a country that manages and oversees its own programs, defines its unmet need, prioritizes that unmet need, and makes allocation decisions against their prioritized list with donor money. They do it without putting the money in their treasury. We created entities that sit outside of the government but are managed by the Ministry of Health, that are completely transparent and auditable. We know where every dollar went. We are smart enough to figure this out and look for corruption, identify corruption, and as we talked about earlier today, have the conviction to engage in corrective action, get the bad guys, but not stop the program because of a fear of corruption or because of identification of corruption. The intervention is really innovation through delivery. We didn't wait to figure this all out in 2009. We engaged the programs and in real time with real programs, altered them and watched what happened. We didn't study it, define it, and then implement it. And I would really be an advocate in kind of real life public health to innovate through delivery. You've got to be able to think on your feet with your colleagues in country, use the data quickly, and live with the results, good and bad, and take responsibility for those results together. And it's not a blame game. It is we are investing in you, your people, and your ability to manage and oversee these programs, and that's our commitment, and that's what we need to do. The Ebola activity, and I have felt it today, you guys are all talking about Ebola. Every academic medical center in the country in one way or another is. And we have been very engaged in both the WHO, UN, and Center for Disease Control dialogues around this, and the flat-out frustration in trying to reinvigorate and strengthen the response that was in place. We're now above the 13,000 total cases. About half of those are confirmed, and the deaths now are approaching 5,000. Sierra Leone, Liberia, they're both slowing down in terms of the numbers of new infections reported in the last 10 days. We'll see if that sticks. Guinea has slowed down more. Then Nigeria, Senegal, Mali have not had any new cases. Same with Spain and the United States. Now, the United States is not in an outbreak. If you were just to be clear. But the amount of media coverage has been just over the top, and I think has confused a lot of people, including some governors, around what is effective and needed. But I think that our ability to control that really is limited. I think that the 24-hour news channels have just dominated and taken it away. I think that the Ebola outbreak is an example of everything that we've been talking about. Looking at something that is rapidly emerging, that needs a coordinated response, and not having that response in place, not having the medical infrastructure to throw resources at to create capability. We see that same deficit in many of our inner cities in the United States and Europe, where in the Ryan White effort in the United States, since 1994, it was apparent that African American women were the majority of the new seroconverters who were becoming HIV positive. 54% of the new HIV positive people each year are African American women. And that's been the case since 1994. You try to turn to the African American community and with money in hand, put money on the table in entities to create outreach, testing, referral into care and treatment services, loss to follow-up strategies, et cetera. But if there's no entity to put the money in, the money can't be deployed, and the programs aren't created, and the outcome and impact you're after is not realized. That same problem is the case in all three of the heavily impacted countries. We need to respond as best we can, and I know Dartmouth is doing a lot, both with individuals who are skilled in both the nursing and medical doctor arena. But it's a huge difficult decision to decide to put yourself in front of this epidemic. At UCSF, we've had very difficult, wrenching dialogue with our junior faculty and our fellows and students who have a strong desire to respond, but to respond without personal protective equipment doesn't make any sense, without a place for you to do the work where your safety issues, the safety issues of healthcare workers, have been worked through in detail, both for not getting infected, but also if you are exposed and infected, that response be laid out so you get the best of all possible care. That has all pretty much been worked out over the last few weeks. And I think we will see in the 27 Ebola treatment units that have been, 17 have been put in Liberia, they're only 18% at human resource capacity. So they're very slowly filling. They're not filling. They're kind of hovering around below 20%. That's going to be something that I think will get more and more discussed in the next few weeks, because the capability to kind of maximize, optimize the protection of the healthcare worker is getting in place. How that will evolve and move into quarantine strategies, which are right now not in place, will happen over the next 6 weeks. So individuals who come to the treatment sites and are told that they're not infected with Ebola, but you're in a period of watch and wait for 21 days, that they're not sent home to, if they indeed end up being infected, that they've gone and exposed all the people at home and anybody coming in and out of the household. And that's why these epidemics in Liberia and Sierra Leone in particular have continued to move out in kind of concentric circles. I do want to say that it's critical that we look at the Ebola response and do what we can, everything we can, to try to blunt, respond to it and push it back. But in that same breath, we need to start a dialogue around what kind of infrastructure in those 3 countries needs to be aggressively put in place. Starting on that now would make a lot of sense. It's kind of a role that an academic medical center could embrace from afar, and I think this is something we need to look toward. Just to remind us that we've been focused on Ebola, rightly so, but that HIV is still devastating the planet out there. Even with all the investment that has occurred and with the remarkable program capability that has evolved in the last decade, we are still seeing unacceptable numbers. The morbidity and mortality continues to persist. So it's about team solving problems together. An integrated team at the country level is really what we're focused on, expanding the capacity of, worrying about creating a cadre of expertise in country that manages and oversees these programs in an excellent fashion. It's really what we need to do. Really understanding, teasing out, defining a new lexicon in the determinants of performance. We need to start thinking of it like that. Determinants of disease, but it's also what are the kind of essential ingredients in a program that has the outcome and impact that we want to buy. How do we ensure that every program has those essential elements so their performance is better assured? Planning together, using a different business model that incorporates a different cadre, a leadership ecosystem, as we were saying before, in country that supports the ministries of health in playing this role is the target. A different approach to find a different model, be willing to engage in different thinking, but also go ahead, take the plunge into implementing it, but have the rigor in your implementation to define the outcome so you know if you are on or off target, and the willingness and ability to make the alterations, not in a 5-year time frame after the program's over, but in that subsequent budget year, so in year 2. And I think that kind of rapid feedback loop and accommodation is something we need to all strive for. The collaborations are critical. They're what sustain it. They're what keep it excellent and keep it, I would say, relevant to the changing needs of the population who often have no voice in the planning or implementing aspects, but are dependent on the services to be in place. I think that is about the collaboration. UCSF has supported me in setting up an Institute for Global Health Delivery Science and Diplomacy. It is focused on targeting the ministries of health for that capacity expanding intervention that we talked about, with all those players converging around that ministry to support them in doing this in a different way. I believe that it is the missing link for our movement to a planet with a basement of essential services, now talked about in the UN General Assembly as universal health care. It's the first time in the human discussion on the planet that universal health care has been spoken to as something we should strive for. And those of us who have been in these dialogues are very gratified that the commitment seems to be there. In no uncertain terms, you should know that the United States is the lion's share of the resources on the planet. We're 300 plus million people that consume a lot of the resources on the planet, and I think have a responsibility to reflect those back because we can and others can't. And I've been very gratified to be in the political arena with political leadership that sees that in the same way, feels that we do have a commitment to those that can't help themselves, and that's very much a reflection of the conscience of the American people. And I am humbled by how much the United States and the taxpayers of the United States have invested in this effort. I saw this quote in the materials that Jessica gave me. It's from John Dickey, the president of Dartmouth. I thought it really spoke to me. The world's worst troubles come from men, and I assume he meant men and women. Or he didn't, I'm not sure. I know Dartmouth was just all men in ties. And there's nothing wrong with the world that better human beings cannot fix. And I really strongly believe that that is something you should take to the bank. And then Margaret Mead's comment that just resonates for me, that it is about individuals. It's always been about individuals changing the world. It's never been mass movements changing the world. And I think this work is going to be a lot of individual efforts that are done in an excellent way with an eye to transfer of that capability to our colleagues in country who are in front of the greatest burden of disease. My age group started a lot of things, but it's you who are going to finish it. And I want to really acknowledge my joy in that there are people who are queuing up. I spent a lot of time with many of them today. Serious, committed, dedicated young individuals who are ready to put their lives toward working to put a quality of health care on the planet that the people on the planet deserve. I think we're at a moment in our kind of evolution and maturation as a species to start really worrying about others. And I think this effort and these ideas are going to be central to the successful achievement of it. So thank you very much. Sure.
Take a few questions.
I'm happy
You
to
want me
happy to take some questions. Sure.
Okay. All right. Well, thank you for a tremendous set of remarks, and now we'll take some questions. So, first hand up right there.
May I ask you to comment on a completely different subject you didn't address?
I tell you what, can you just wait for that mic? Right.
Sorry. May I ask you to comment on a completely different subject, which is population? Clearly, the application of modern science to very poor societies has had a huge impact. Uganda is one country I'm familiar with. A few decades ago, it had a population of 8 million. I believe it's about 30 today, and it's heading very quickly for
33.
140.
Yeah.
Huge changes. These countries are totally unprepared for. Where does that fit into all that you've told us?
You know, you make me, you're right to call it, it's a central issue, not peripheral. The fertility rate in Uganda is 7 for a woman. The average woman in Uganda has 7 children. It destabilizes the family, and the family economics never catch up. It dilutes the resources that the family does have for education and food and clothing, housing, etc. You see society struggle because of a lack of a family planning agenda. President Museveni really, and his wife, actively fought the family planning dialogue. Every one of us brought that dialogue too, from the Secretary of State, the President, when he spoke to Museveni, it was on his talking points, the family planning issue in Uganda. And it was because it is at the central core of their ability to move the resources that are available to them, to distribute them throughout their society, so there aren't a lot of discrepancies, disparities in personal wealth and access to services. So I think the family planning issue is a central issue that needs to be addressed, and it should be part of this narrative as well. Yeah, we can't dodge it.
Okay, I'm going to jump in, if I may, with a question. Oh, you want to go first?
You want to go first?
I'll go first then. One of the things that I find so fascinating about your presentation is the emphasis on building capacity in governments. And when I was working alongside you in a very different kind of field, I found that one of the hardest lifts, one of the most difficult tasks, was to convince legislators to build capacity. It is easy to get $50 billion for DOD to go take care of a problem after Department of Defense after it's erupted. It was unbelievably hard to get Congress to appropriate $100 million to make sure that that problem didn't happen, because you built the capacity. My sense is that you were more successful and that the healthcare sector is more successful with this, but I'd be curious about your reflections on whether you saw that problem as well, and if so, any prescriptions for dealing with it.
Well, Dan definitely saw the problem. We were in a constant dialogue with appropriators around money for this program. And the unusual bipartisan support of it, because it was created by President Bush, gave us some cachet. But it was mostly people seeing the programs themselves that got the buy-in. Taking appropriators, most all of them, and their family, wives and children who were interested, and giving them tours in country when they were there, or on a couple of occasions each year actually bringing appropriators to see the sites. The argument that won most minds was do you want us to create an entitlement, or do you want this to be a baton pass? And we can continue to pay for these services, but what we now need to start doing is transferring the management oversight initially, and eventually the paying for these services to the respective country. And they liked that narrative as, you know, this isn't going to be here forever. We feel good about what you're doing, but we don't want to do it forever. So we really are happy that you have kind of a plan for how this goes on, but we're not the main on the dole for the price of it. That's what won the most support, was that.
Well, I'm really impressed that you traveled voluntarily with members of Congress too on your free time. So, all right, Lisa.
Thank you for your thoughtful talk and your insights into this complex topic. I really liked your slide showing the stool and the four legs of the stool as the sort of essential key partners in effective healthcare delivery. And there already is some coordination and collaboration across those four entities, but I'm curious to hear your thoughts about how do we further that? How do we foster more coordination, collaboration, and real engagement across those four partners? Is that something that should be donor-driven? Is it something that should be in the hands of the in-country leadership or some other option?
Yeah, that's great, Lisa. Great question. I think it should be donor-supported. I think that the identification of institutions in the country that have capability are not identified, and the links to those institutions have not been created largely. The role of academic medical centers, of medical schools in these countries is usually focused much more on just getting the cadre of physicians trained and out the door. They do not see themselves as part of or an extension of supporting the healthcare in the country in that kind of specific way. We have had to create those linkages in what are kind of twinning relationships with academic medical centers and our academic medical centers to get them to grow on all the levels that an academic medical center needs to grow to have that capability to support a Ministry of Health. It's not just one or two people, it's the whole institution. Even though there are relationships that come from many of the people in the Ministry of Health coming out of those institutions, but the institution as a resource is a new idea. So I think that needs to be jump-started, with some funding that did it. We supported the medical education MEPI and NEPI programs. The MEPI program took on, in a different way than the NEPI did, became more what we wanted, a network of academic faculty that had skill sets. We partnered with the Fogarty Institute to have them manage this program, bringing a cadre of faculty in front of more training on how to do clinical research and how to do what I would call impact evaluation. They were given the tools to do clinical research, identify their own questions and answer them. And it also created a layer of clinical faculty in the in the hospitals, the teaching hospitals, that were not there for the most part, where there was someone there just for the training needs of the young physicians as they came out of medical school. The network that they created, the curriculum revision that they went through, took it to organ systems, so the cardiovascular system for anatomy, pathology, physiology, pharmacology, all in a series of lectures that were a unit lecture. And it created interns that were much more confident with a differential diagnosis and with a work plan. But it also kept them in the hospital at night, where they covered and admitted the patients with the residents, which was critical. I think that's the beginning of a kind of a reinvigoration of the academic medical center in Africa, which has been ignored for many years. But it was taken up with great vigor. The faculty loved it. They did more than we expected from it and created a network that touched, it was 18 medical schools. It spread to 37 medical schools, all on its own. We funded 18. We made them principal investigators for an NIH Fogarty grant, which they also loved. But we didn't have an academic. They chose an academic twin in mostly the United States, a couple in Europe, a couple in Africa, as the other institution that would partner with them to move them through this. So I think donors do need to invest in this. And when the schools get strong enough, they can start to do it on their own when they start to attract their own grants. PEPFAR made it a policy that our monitoring and evaluation requirements be done by that medical center. So not turn to Columbia or UCSF to do the M&E, have it done locally, and got Columbia and UCSF to support that local academic medical center to play that role. They're still doing that.
Thank you very much. This has been incredible, actually, learning about some of the connections and actually springboarding off what Lisa asked about the expanding of the programs. You talked earlier on about the sustainability of these programs really being predicated on a decrease in the disease, so that the only way you could turn it back would be as if there was a lower and lower burden of disease. You also talked a little bit, though, about the blueprint of adding on other services. You talked about the Red Ribbon, Pink Ribbon Alliance as an additive piece to PEPFAR. And do you see that as being a way for donors to continue to engage? I mean, I was thinking of the family, reproductive health would be a great addition, but there are some donors that wouldn't necessarily agree to that expansion. Can you tell me a little bit about that, aside from the education expansion? I'd love to see what you see the donors' best plan to be.
Yeah, it's a great question. I think the PEPFAR platform, not just because I was involved with it, but because it's true, has doctors, nurses, healthcare workers, laboratory people, up and running laboratories that can do your basic, CBC and liver function metabolic panels, but also CD4. The PEPFAR labs will all do viral load by the end of middle of next year. I think if they can do that, they can do any lab tests. Those nurses and doctors can be used to look for high blood pressure, fasting blood sugars, lipid panels for diabetes, coronary artery disease, and immunizations certainly could be done there. But family planning is a no-brainer. A lot of maternal and child health is a no-brainer. I really wanted that to happen when I was there, and so did Secretary Clinton. Worked on it, but the bureaucracies in which Dan and I worked often won, and this is an example of them winning. I couldn't get the U.S. bureaucracy to free up their concept of where the family planning services should be located, and God forbid that they would put them on top of a PEPFAR platform. We're already there, but no, we're going to go down the road and build another one. And so I think there's we could have a lot of wins if we just changed the way we did our work around that. UNFPA would love to piggyback on, but they don't really have the resources to pay for the programs. It really would work best if the US dollar that pays for family planning services piggybacked on these and keep what sites you've got in any given country, but add the PEPFAR sites to it. And so there's still dialogue around that, a lot of will on PEPFAR's part to do it. USAID is changing in terms of its willingness to talk differently about it. I think it would take the Secretary of State to say do it for it to happen, though, quickly. Yeah.
From experience, I can tell you that sometimes Secretary of State will say things and it still won't happen.
It still won't happen.
Sometimes the president says things and they still
know.
don't happen. People find that hard to imagine.
It is
We have
true.
a question over here.
I have a question for you. A couple of times in your presentation, you referenced the fact that that for PEPFAR to be successful in the future and some other programs and initiatives similar, we're going to have access to real-time data to make good decisions. That's a huge problem domestically. And so if you have great examples of where that's happening successfully ex-US, that would be really wonderful. But how reasonable is it to expect that we'll be able to make decisions with real-time data and decide what to continue to fund, what to scale, what to not scale going forward?
It's probably a reach. I'm talking about having the information that that site or those clinic sites gather and send north looked at once by those who gathered the data to see what their institution is doing and who's doing it, to have it just posted. Don't analyze it. Just post it would result in change that would be for the better. So I'd be happy with any movement in that direction. Even if it were 2 years, 3 years out, it would still be better than what's done now, which is nothing. Data collected, sent north, never looked at again. Ryan White had that same problem. The San Francisco General AIDS Clinic, place dear to my heart, actually refused to do any data because they felt they were too busy, and they were busy, but they felt that it was a distraction from the real work in front of them. And for 2 years, they didn't accept any Ryan White money, and they have 25,000 AIDS patients. So it's like, then they started to, but once you inoculate the site with data feedback loops, they eat it up and they want it, so they drive it once you get it going. So my naive thought is that we can get it going and it'll kind of self-propagate. Even if it isn't perfect, it'll be better.
Do you have any more questions? There's an arm in the back.
Great. Thank you so much for a great day. This afternoon, we spoke about the importance of elevating the status of the ministries of health in the countries where we've been talking about today. And I'm just curious from a diplomatic standpoint how that actually happens in real time. So I can understand when there's a lot of donor money coming in, if it is being funneled through the Ministry of Health, it would be easier for them to have status. But long term, how do you promote that investment in that department?
Yeah, it's a real struggle, and you're absolutely right. When any Ministry of Health included, gets money, they rise up in the interest of their colleagues at the cabinet level and the president. Getting the health care of the people on the political agenda of the people and the president is the trick. So having a civil society that demands health care, that speaks to their government about having it or not having it, that holds their government accountable on some level to the quality of the care that's delivered. When it's not delivered, that there be consequences for it, and that a politician in a country begins to feel a political swell of support that is generated behind this issue is when you start to see a change. And that's hard. I don't know how to exactly get there, but I do know that supporting civil society in kind of peer support, educational interventions, targeting those that are in and of the community, well interfaced with the target populations, to be the means through which you deliver your healthcare messages, your loss to follow-up type interventions coming out of that already credible and trusted cadre of people, empowers them to be vocal about what they are or not getting. And politicians, when they see that, see it as a potential kind of wedge issue that they can use for a political advantage. So you see them start campaigning on it. President Kagame in Rwanda is a good example of that. Kikwete in Tanzania is another example of that, where the political, his political campaign included health services and educational interventions. Zuma, South Africa, is a terrific example of making HIV a central campaign pillar and having a constituency that's created that holds them accountable to continue it.
Okay, I think that does it. I want to again thank Dr. Goosby for an incredibly informative presentation. and for submitting to the Baton Death March approach to a visit here at Dartmouth.
Yeah.
You've been very, very kind and generous with your time and with your engagement, so thank you.
It's a pleasure. Yeah, it's great. It's great to see you.